Hey everyone, it's Adam again, and this is actually our last lecture for EpiBiostats. I'm sure some of you guys are very depressed about this, but thank goodness for YouTube, you can go back and watch it over and over and over again. Anyway, the last lecture we're going to be talking about improving decisions in clinical medicine. So kind of bringing it all together, seeing how you can apply all the stuff you've kind of learned in this class into how you can apply it to patients that you're taking care of. And the objectives we're going to cover today. So one of the big things you'll hear about as you go through your time here in school is about evidence-based medicine. And basically just what that means is we're taking all the clinical research we have available to us to kind of inform us what is the best thing we can do for our patients. You'll find some people, some providers who have been doing the same thing for the past 20 years. That doesn't always mean it's the best thing for their patients. They may think it works great, but really that's just anecdotal evidence. So you really need to have these kind of large, well done trials in order to show us what's the best thing for our patients. And so it's really important that we are able to incorporate these things and take this information from a large population and apply it back to our individual patients. And so we're going to be talking more about that today. So in order to practice evidence-based medicine, you need to make sure you have access to relevant research data. So for instance, I'm a toxicologist, and so I read toxicology journals. I try to keep up to date with that sort of thing. You have to be able to decide what's trustworthy and applicable, which is kind of what we've been talking about a little bit with some of our journal clubs. And then be able to use the methods to appropriately kind of determine, based on this evidence, what's the best diagnostic and therapeutic approach for your patient. So one of the first things we're going to do to talk about how we can apply some evidence-based medicine to our patients is with using Bayesian statistics or Bayes theorem, which we've kind of mentioned in the first section of the class, but we'll kind of cover again here now that we have a much better tool set to kind of understand and interpret some of this information. Basically, when you have a test, it's really important to know the sensitivity and specificity of a test, know just how well it can perform in identifying, true positives, true negatives, things like that. And so when you have a test and you decide to use it on your patient, two questions you have are, if the test results are positive, what's the actual probability that the patient has the disease? And if the tests are negative, what's the probability the patient does not have the disease? And so we talked about positive predictive values previously and things like that, but Bayes' theorem is also going to help us with a way to answer these sorts of questions. Now, if you're looking to calculate Bayes' theorem, this is kind of what the formula looks like, and it looks intimidating, I agree, but we don't really have to worry ourselves so much about the details here, right? So you can go through and read what the different variables are specifically. We'll throw in the towel when it comes to this sort of thing and just say forget it. But basically what we're seeing is that Bayes' theorem helps us to determine what the positive predictive value is for a test. We've talked about that previously, so you guys have an idea of what a positive predictive value is, basically saying if my test is positive, what's the probability that my patient actually has the disease. And this is important because it's going to go back and we remember that positive predictive value, negative predictive values, those are going to be contingent on the prevalence of disease in the actual population we're dealing with. And so we can see how this theorem, I'm going to show you how it's going to apply back to affecting the test results you get based on the type of population you're dealing with. Basically what you find is that in a population with a very low prevalence of a particular disease, it is much more likely you're going to find false positive results in, say, like a large screening program, right? Basically, you can do a large screening program for going back to the example of high calcium with hyperparathyroidism. You can do that in a large number of people. If it has a relatively low prevalence in the general population, you're going to get a lot of false positives, right? Now, it doesn't mean that the screening program is no good, but it may raise questions about how cost effective it can actually be. And so if you go back to the very first lecture we talked about, talking about HIV prevalence and looking at, they were doing a study where they're trying to test all newlyweds for HIV, and they were seeing that it was just really not cost effective because the prevalence of HIV was so low to begin with that you were getting all these false positive results. But we can kind of take these points and look at some other examples of how Bayes' theorem can be very useful in helping with these sorts of screening programs. So one example of using Bayes' theorem to help with these community screening programs is with these tuberculin tine tests for kids. Basically, this is the test where kids were given small amounts of tuberculin antigen on these tiny prongs called tines. And basically, you pierce the skin on the forearm, leave some antigen behind, and then 48 hours later, you should see an inflammatory reaction. Or if you did see it, it was considered a positive result. And so one of those things that we were looking at when determining, the performance of a test is we kind of knew who had the disease and who doesn't. When using Bayesian statistics, basically what we're looking at is we have an idea of what the general population prevalence for disease is, and we're going to be incorporating that information into it. And so basically, when you have a screening program like this, you would have an idea of the general population of what the prevalence of tuberculosis is in the community, right? So that's going to be important when you're trying to factor that into how many false positives results that you're going to be getting out of this, right? Because you don't want to accidentally identify someone's having tuberculosis. They really don't, especially with treatment being so severe and things like that. Yes, there's lots of issues with that. So you want to try to mitigate how many false positives you have as much as possible. So the next slide is going to have a table that will show how some of these calculations are made. But let's say, for instance, we have a test that has a sensitivity of 96% and a specificity of 94%. Sounds pretty good, right? Well, if we know beforehand, kind of a priori, that the prevalence of TB in the community is only 1%, then we do the calculations, which I'll show you here in a second, only 13.9% of those tests with a positive result would actually be infected with tuberculosis. So again, that means you have a high proportion of people who are testing positive that don't actually have the disease, which could be a waste of money. You may need to do follow-up testing to see if they actually have it. You could have people getting unnecessary treatment. You can see the inherent problems with this. So let's see how the actual math is done here. So we've seen tables like this before, but let's go ahead and walk through it. So looking at the actual test itself, kind of beginning data, we're going to see that the sensitivity of our test, this time test, is 96%, right? So again, or 0.96. To go along with that, remember that sensitivity is going to go along with the false negative rate, and both of these should equal 1. Okay, so if it's 96% for the sensitivity, then false negative rate needs to be 4%. Similarly, with specificity, about 94% specificity along with 6% false positive error rate, so these two should equal 1. And then looking at the prevalence of tuberculosis in the community, you need this information beforehand so you can kind of do these interpretations, but we said that was 1% or 0.01. Plug it into Bayes' theorem, and again, you only have to calculate maybe like 5 or 6 of these on the test. Just kidding. But actually going through, you'd see you get a positive predictive value of only 13.9%, right? So the probability that you have a positive test that the patient actually has the disease. And you can make one of those 2x2 tables, and let's say that we're dealing with a study of 10,000 patients, right? So again, only 1% of those are going to be actually diagnosed with or actually have TB. So if you put these into the test, you'd see that out of the 100 that actually had tuberculosis, you get roughly 96 people who were tested as true positives. You get 4 false negatives here, right? Because these are people that actually have the disease. And then on the side of people who are non-disease, you have 594 false positives, right? So 6% of those who actually didn't have the disease are going to get tested positive, and 9,300 true negatives. Okay. So looking at this, you captured 96 people who actually had the disease, but you're also falsely identifying almost 600 people who didn't have it. I think the total would be 690 total positive results based on what we're seeing here. So looking at that, you're only about 13.9% of those people who tested positive actually had the disease. Not great numbers, right? That's our positive predictive value. So is that good enough? Possibly. It depends on the type of disease you're dealing with, how severe it is, how costly it was to do the screening in the first place. But it looks like you're not getting a whole ton of return on your investment in this particular instance, at least. Now, these types of screening programs, the first time you're applying this to an unscreened population, you may actually find you have a pretty considerable number of cases of the disease being found. And then upon repeat screenings, you may find you have a lot fewer people actually being identified. The reason for that is that the first screening, you're typically capturing a lot of people who have never been diagnosed before, so there's a lot of prevalent cases that had not been caught previously. Whereas with the second round of screening, those people don't need to get diagnosed again necessarily. Those are going to be new incident cases that have occurred in that time frame between when you did the first screening to the time you did the second screening, essentially. Now, suppose you're a clinician and you're uncertain about a patient's diagnosis. You got a positive test result for a disease like, say, TB or HIV. Even if you know beforehand what the test sensitivity and the specificity is, it doesn't really solve your problem unless you know what the actual prevalence of disease in the community is, or at least the population that your patient is a part of, because you need that in order to do the positive predictive value, or to use Bayes' theorem, right? And so depending on your patient, they may be part of several different populations, which may, lead them to have different prevalences based on that. So for instance, if you're looking at a patient who is, say, a homeless IV drug abuser, that's going to be a much different prevalence of things like infectious diseases than you would see with someone who is, say, from affluent neighborhood who had plenty of vaccinations and things like that. So typically, based on the type of patient you're dealing with, though, you can at least get a rough estimate. We're never going to know the actual true prevalence of disease in a given population, but due to things like epidemiologic data, health department, things like that, we can at least get a decent idea. So let's look at another clinical example where you can apply Bayes' theorem. And so let's say we have for instance, we're working in a general medical clinic and you have a male patient who shows up and he's got easy fatigability and he's got a history of kidney stones. You don't find any other signs or symptoms of parathyroid disease on physical exam. So you're kind of evaluating him and you're thinking, okay, is this hyperparathyroidism? You decide it's probably pretty low. You imagine, and we're going to call this a pretest probability or a prior probability. The prevalence of hyperparathyroidism in a patient like this would be, say, 2%, right? So we're thinking there's a 2% chance this guy actually has the disease, okay? And so we want to go ahead and try to rule out the diagnosis. And so we can do that first off with a pretty cheap lab test. And here we're going to check our calcium. So we're going to go ahead and order calcium to rule out the diagnosis of hyperparathyroidism. To your surprise, the results come back positive. The guy has an elevated calcium of 12.2 milligrams per deciliter. So now the question is, okay, should I just start to do a bunch of other tests? Should I check a PTH level? Should I do this and that? And you're going to find that some come back positive, some come back negative. But there's a better way that we can apply Bayesian statistics to try to figure out, okay, what's the probability based on this test that my patient actually has the disease? So basically, this is going to give us a secondary estimate after we've performed that test to see how likely it is that patient actually has the disease based on our prior probability, this kind of pre-test probability. And so what we're going to get out of this is going to be our posterior probability. We're going to get this positive predictive value. We're also going to call our posterior probability. And I'll show you a table how we're going to get that in a second. And so by incorporating in that prior test probability, that 2%, we think prevalence of hyperparathyroidism is in a patient similar, in a population similar to our patient, and then factoring in the sensitivity and specificity of the test, we're going to be able to get that posterior probability, that positive predictive value. So let's say, for instance, our serum calcium test had a 90% sensitivity and a 95% specificity, right? So this would imply that it had a 5% false positive rate, okay? When you're going to use that information with Bayes' equation, as I'll show you here in just a second, you're going to get a posterior probability of 27%. That means that the patient is more likely to actually have the disease, but it's certainly not anywhere near certain, right? So a little bit better than a quarter chance that this guy actually has parathyroid disease. And so let's look on the next slide, and we'll see the 2x2 table and how we figure this out. This is going to be the exact same as we did for the test we're looking at, the tuberculin test, essentially. But looking at the sensitivity of the test, it's 90%, specificity is 95%, and then that prior probability or that prior prevalence we assume is 2%. Factoring that in, and then again, you can see the 2x2 table here. If you were to do the same test and say 1,000 individuals, very similar to our male patient, you would see that basically you'd have a 27% chance that this patient actually has the disease based on your prior prevalence. And again, I'm not going to make you do the math here, but the interpretation is the important thing that you're understanding, or why we're doing these tests in the first place, to try to determine, why we're using the statistics and how this can inform our clinical decision-making pathway. So now we're going to do a follow-up test. We think now we have a 27% posterior probability that the patient actually has parathyroid disease. And so we decided to go ahead and order up a second test. And so now we can actually do a parathyroid hormone test on this guy. You don't want to start with this because it's pretty expensive compared to just serum calcium. So this is why you want to start off with cheaper, less invasive things and then kind of move up the pathway based on what those results are. And so let's say, for instance, our PTH test came back with a sensitivity of 95%, specificity of 98%. And the results turn out to be positive. Now we can, instead of using that 2% that we originally had as a prior probability, we can sub in this 27%, the posterior probability from the first test, and now kind of use that as our prior probability for the PTH test. Now, if that were to come back positive, this would change our new posterior probability to 94%. So now it's much more likely, based on the fact that we have a positive calcium and a positive PTH level, that this patient actually has hyperparathyroidism. Again, looking at this test, here we have PTH levels has a 95% sensitivity, 98% specificity, and then that 27% prior probability. Now incorporating all of this in, we can see that it's much more likely that if the patient has both of these positive tests, he has hyperparathyroidism. It's almost near certain at this point. So you might be questioning, why did the posterior probability increase so much the second time? One reason is because our prior probability has gone up quite significantly from 2 to 27%. But the other thing is again, when you are doing your testing to see if you want to rule things in or out, remember snout and remember spin. We want to use tests that have high specificity to rule things in, because we know with a highly specific test, there's a very low false positive rate. And so because of that, we have a very low false positive rate because this one had a 98% specificity, so near 100%, and this helps to increase that positive predictive value quite significantly. So again, a highly specific test is useful for ruling in a disease. You can use something with higher sensitivity to rule things out earlier on in your testing paradigm. And again, when you have so many tests available to you, it's important to consider, should I do these simultaneously? Should I do them sequentially? But remember, high sensitivity tests rule out diagnoses because they have a very low false negative rate. Tests with high specificity are used to rule in diagnoses because they have a very low false positive rate. So if you find someone's really positive, then you can be relatively sure that it is a true result. So in doing these sequential tests, you should probably start with the most sensitive ones first to try to rule out diagnoses, and then you will move on to increasingly specific tests until you find something that yields a negative result, and then you can rule out that diagnoses pretty definitively at that point. And so it's typically more conservative to do this kind of sequential approach rather than just doing all the tests at the same time, but it can make your interpretations a little bit more sound, can make a more economical sense in some cases, although it may be unclear. If you have to do a send out test that takes 3 days or a week to come back and your patient's in the hospital that whole time, that may not balance out necessarily. So it's hard to say the full kind of economical consequences of this kind of testing pathway. The problem when you do all the tests together at the same time is that you tend to kind of gloss over negative results and only look at the abnormal things, and it can be more difficult, can lead to false conclusions if you regard them all that way. And so in general, you should probably consider the ones that have the highest sensitivity first, so that way we know that highly sensitive tests are going to have a very low false negative rate. So if that gets reported, that's probably really is a true negative. And then again, going on to the more specific tests as you go through until you get something that's really negative. And again, when you have a bunch of tests that come back out at the same time, sometimes ones can contradict other ones. It can make it more difficult to make the correct diagnosis. So try to look at them in a kind of a sequential approach, and that usually will lead you towards the right answer generally. So another pathway you can take, another approach is called decision analysis, and this is trying to help us to make better decisions under conditions of uncertainty, because a lot of times you may not have, it's nice when the patient shows up and says, hey, I have appendicitis, and they're right, but it's not always so clear in a lot of cases. And so you can utilize some of this decision analysis either to apply it to groups of patients that present with say, a particular complaint, or to an individual patient. Probably done a little bit more clinically than you see with Bayes' theorem, and this is being used a lot more in the literature, and especially when you're trying to evaluate a whole class of patients. Like these kind of decision pathways, based on, okay, patient you suspect a PE, they come back with this test and these symptoms, how likely they are to actually have the disease. These are kind of things you're going to be looking at a lot in the literature as you go forward. And so these decision analysis pathways are generally better used as a tool rather than the absolute law of the land and how you should treat every single patient. But it helps incorporate several bits of information, things that like the data that goes into making a decision, talks about the sequence of decisions and how they should be made based on things like how invasive certain tests or certain procedures are going to be. And then they kind of help to align with the patient's personal values that have to be considered before you make any serious decisions. Should I operate or should I wait? That's an important decision that has to be made with the patient, right? And so these kind of decision analysis trees can be helpful with that. So there's kind of 5 logical steps when you're setting up a decision tree. You want to identify and set limits to your problem, diagram out your options, and you're going to obtain information concerning each option. You'll compare utility and then perform sensitivity analyses. And we're going to look at this as we go through each of the steps here. So when you're trying to identify the problem, you need to consider kind of what are all the possible clinical decisions you can make here, and then kind of what the sequence these decisions should be made, and kind of the possible patient outcomes after each decision. So the example we're going to use here is a patient who shows up with a silent gallbladder, silent gallstones. Should we remove the gallbladder or should we wait? What should we do with those kind of patients who aren't really presenting that symptomatic, but they have these gallstones? So the beginning point of the decision tree is obviously the patient's current clinical status. So how are they presenting to you? And then at each of these points, you're going to have these decision nodes, right? So this is defined as a point where you're going to make a decision to do one thing versus another. These typically get defined or get outlined as either squares or rectangles. And then you're going to have chance nodes. And so they're going to be defined where as points where you have to wait to see the outcomes, right? And they often are represented by circles. So if I wait, does the patient progress and they get some complication and die? Or if I decide to do surgery, what are the possible complications after that? Okay, time generally goes from left to right, and then you'll find the first decision is going to be the left, and then subsequent decisions will be kind of progressively to the right there. And so our beginning point in this particular case is going to be the presence of an asymptomatic gallstone, and then our decision, initial decision node is whether to operate immediately or to wait. So here's an example of our decision tree. Basically, walking you through it, you'll see that here we're starting out with a silent asymptomatic gallstone, right? And so our decision is, should we wait or should we operate? Obviously, if we operate, the probability of this course occurring is 100% because we decide, hey, we're going to take you to the OR. And then looking at, and usually this is kind of expressed in the literature somewhere, kind of using kind of reference values, but looking at the probability of death occurring is about, say, 0.4% for your patients here. So pretty low probability of death, but not non-existent because again, you are performing surgery here. Now, if you decide to wait, you have to go to the chance node here where you can find your patients may undergo several different courses here. So you'll find that the probability of this course, notice here that when you're at one of these nodes, that all of the different options should equal up to 1. So if I add all of these up, they will equal out 1. So again, the patient is going to go one of these directions. Now the majority of them, 81.5%, are going to probably remain asymptomatic. And looking at the probability of death, if they're asymptomatic, no issues, hey, they're not going to die from that, right? Some of them are going to go on, about 15% to develop biliary pain. If they develop that, they'll probably end up going to surgery. And again, that death probability is the same as if they had done surgery in the first place. You'll have some that will undergo complications like acute cholecystitis. Again, the death probability goes up a little bit there to 10%. And then with cancer, a very low number of patients are going to develop cancer here, say 0.5%. However, death is very, very likely in those cases. So here's your kind of courses here. Here's the different ways that the patient could go with the probability of death associated with that, right? And so again, this should inform your decision pathway. Okay, should I do surgery now or should I wait? This is how these trees are kind of set up typically. Now, the probability of each of those outcomes I mentioned either comes from published studies or is estimated based on clinical experience, things like that. Now, again, if the clinician waits rather than operating, 81.5% will remain asymptomatic. So a grand majority of those patients will be asymptomatic. 15% will have biliary pain, which may require them going to surgery. 3 are going to develop complications, such as cholecystitis, right, or common duct obstructions, things like that, and then 0.5% may develop cancer. Okay, so again, they should all add to be 100% because again, the patient is going to go one of those directions. With 100% probability, they're going to go down one of those pathways. They should all equal up to be 1. And then there's this idea of utility with your final outcomes. Obviously, you can have positive and negative utility associated with different outcomes. So for instance, a patient lives a certain number of years disease-free. That's generally pretty good. You want to have high values associated with that utility. On the other hand, when you have negative things like death, illness, cost, you would typically want smaller values for that. So greater utility comes with smaller values of these kind of undesirable outcomes here. And so again, you're going to find that a lot of these clinical decisions are being made in order to try to maximize utility, both from a cost perspective and also for quality and quantity of life for the patient. As I said before, here in that tree, they're going to be using a negative utility as a probability of death occurring. If we do surgery right now, probability of death is pretty low, but still not non-existent, so 0.4%. If they decide to wait and they remain asymptomatic, death rate is probably 0% from gallbladder complications. And then if they have biliary pain complications, cancer, notice how the death rates continue to increase. So it's a very low probability that patients would develop cancer had you waited. However, their likelihood of death is much higher than if they remain asymptomatic. So again, kind of makes sense from a clinical standpoint. Now, in some cases, you may find decisions tree that show one choice that is like clearly preferable to any other one, and there may be really good, strong evidence in favor for that choice. In a lot of cases, you may find that it's not so clear. It gets to be a little bit more vague or murky when you have several outcomes that have similar utility. So you either need to have better data to kind of inform those decisions and those probabilities of utility, or you have to consider other factors in the decision-making process and let that factor into you making your clinical decision. This is where like patient preferences and patient values and things like that are going to come into play here. Now, sometimes when you're comparing utility values, it's helpful to perform what we call sensitivity analyses. And you may have heard about these before, but basically this is where you can kind of change different features of the data. If you change different assumptions that you're making and see how they have an effect on the outcomes, the outcome utilities, it may lead you to think, go down one decision pathway or another. If, you change some of these variables and really the outcomes don't really change that much, and that shows you that it's pretty stable, it's very unlikely to change due to, the absolute, whatever happens with your patient essentially. And so, but you may find they change pretty drastically, which means, a lot of times you need better data in order to kind of inform those decisions. But one of the ways we can try to compare utilities between these different nodes here is by comparing the overall utility between several decision choices or several outcome options versus this one decision here. So for instance, when we're looking at the case of these two branches, the decision node, we either operate now or we wait. And we mentioned that the probability of death from operating was 0.004. So 0.4% of patients after surgery would die essentially. And we saw that from the wait standpoint, there are 4 different probabilities of death, and we saw that there was a different likelihood that each patient would go down that pathway. So, very likely they would be asymptomatic, very unlikely that they would develop cancer, even though that was much more likely to cause death. So what you could do is actually average that out by including the probability of that outcome multiplied by that probability of death, and then kind of averaging out those 4. If you did that, you would actually end up coming out with this 0.009, which means that if you decided to wait, you'd have a little over twice the risk of death than operating now, based on the chances those patients undergo any 4 of those outcomes. And so based on those previous calculations, you may think the best option would be to operate now, right? Because again, it has a lower chance of death. Patient is unlikely to have any of these other issues develop as a course of waiting. Now, those are not huge differences in numbers there. So again, it's one of those things where it's not super clear that yes, this is the definitively good choice to go with. And it could have a lot to do with, what does your patient want to do? What is important to them? Do they want to undergo surgery? Do they not? And so you'll find that in a lot of cases, you don't have one clear-cut winner in every single case. You may find that over time, the balance may shift based on newer assumptions or different data, but it can be useful to do the sensitivity analyses where you kind of change a little bit of the variables here and there to see how that will have an effect on the outcome, and kind of help to inform you, the clinician, and the patient how to best make a decision here. And of course, there's lots of other factors than just this probability of death, because if someone had surgery and then died, that would be pretty immediate, versus if it was gallbladder cancer that got them, that would take many years for it to occur. And so depending on your patient, they may want to avoid things like surgery and deal with those complications if they show up. And then other people will say, hey, just take care of it, just get rid of the thing, gallbladder, and I won't have to worry about it ever again, right? So again, patient preference really comes into a lot of these decisions. So we're starting to find these decision trees are being increasingly applied to different kind of public health issues that are showing up. And so for instance, if you're trying to figure out what's the most cost-effective strategy for eliminating a problem such as hepatitis B, you can utilize the decision tree analyses to come out with several options, right? So for instance, you could do no routine hepatitis B vaccination. You could potentially do a screening program where you would vaccinate following people meeting certain criteria, or we could just do routine vaccination for specific populations. So for instance, newborns, high-risk adults, general U.S. population, so you have lots of different options here, and the outcomes will change based on the decision nodes. So the next thing I want to talk about is going to be meta-analysis. And so meta-analysis is essentially this collection of different papers and different sources of data to try to collate them all together to answer a particular clinical question, right? You're trying to figure out what's the estimated effect of a medical intervention. You're trying to figure out how to best treat patients, what's the best technique for certain things. And so it's important to kind of understand kind of what goes into designing one of these meta-analyses. There's different techniques for it. One of the big ones you can always go and check out is called the Cochrane Review. Cochrane database or Cochrane Review of Meta-Analyses, it puts out several of these throughout the year, and they will try to answer different clinical questions. What's the best drug to use for this? What's the best technique? How should we treat this disease? And they answer all kinds of questions by kind of taking all this kind of heterogeneous data, all these different studies that are done, kind of putting them together and trying to incorporate all that information to come up with a final answer, essentially. And so this can be really useful if you have multiple studies with a similar intervention, but very small sample size. That way you can kind of pool them all together to have kind of one large sample size. And so it's important to know that they kind of help to get greater statistical power and help you have more certainty with these answers. So meta-analyses are not perfect. There are some detractors from them saying that, hey, you can't just take all this, disparate data, combine it together, and think you have some kind of new answer. But as time goes on, as these approaches to synthesizing this new data gets better, we're going to get better results as time goes on. So some of the concerns are going to be included the type of studies that you're going to include in your design. You don't want to include just a bunch of really kind of crummy data. You want to make sure you have good quality trials whenever possible. And so you'll find that there's a lot of techniques to try to get around that, to try to only include the best data as best you can get, and to try to make sure you're comparing apples to apples and not, apples to, I don't know, a Volkswagen. So the two types of meta-analysis I'd like to talk about today are going to be about pooled or quantitative meta-analysis and methodological or qualitative meta-analysis. And so basically what a pooled meta-analysis is going to be doing is trying to look at this from a quantitative standpoint, and they're trying to get a better overall estimate of the amount of benefit or harm that a particular intervention or exposure might actually have. And typically what they're doing is they're kind of pooling data sources from multiple studies that are out there about the same intervention essentially. And so we're calling this a pooled analysis. Again, many studies are being, the data within it are being used to calculate these different parameters, different risk ratios and odd ratios from that data. And again, it's really important to consider, like, how was this information collected? Were they using the same definitions for different outcomes or different events, things like that. And so again, really making sure that they are being very explicit when they're doing a meta-analysis about how they ensure that the data they're collecting and pooling together is pretty homogeneous. And so because there can be a lot of issues about the quality of data that you're including based on the type of article and where it came from, you can, based on which type of studies you include or exclude, you may get totally different results. And so it's really important that they are explicit about what data or what studies they're excluding and why. And then they oftentimes will do sensitivity analyses where, again, they just kind of change the variables. They'll change the type of studies they're including or excluding in order to see how that changes the results. And if they do things like change a lot of those results and they don't really find a big difference, then that leads you to think those results are a little bit more robust, and that's more likely to be the actual true answer than if you were to change, a few studies that was included and all of a sudden you get a totally different result. That kind of leads you to think that there probably needs to be more data to really kind of support that before you could really think it's the right answer. The other type of meta-analysis you might do is what we call methodological or qualitative meta-analysis. And so this is going to be more likely to look at things like, is there a benefit at all to doing this particular intervention, as opposed to actually quantifying how much of a benefit there is. And so again, this is going to be evaluating the quality literature that's out there regarding a particular topic, and it kind of gets scored based on a list of objective criteria. So it kind of looks through these different studies to determine which ones have kind of the strongest methodology to them, which one can you say, is most likely to really answer the question in a consistent manner. You may also find this referred to as a methodological analysis or quality scores analysis. So in some of these cases, you may find that methodologically speaking, the strongest studies tend to agree with one another, whereas, say, weaker studies will disagree, right? And so a lot of that has to do with power and how many people were involved in their studies. So a good example of this is a meta-analysis that was looking at different trials of the BCG vaccine against tuberculosis. They found that only 3 trials really met all or almost all of their criteria to be a good study, quote unquote, and had very precise statistical estimates. And they agreed that BCG was effective at protecting against TB. Whereas you had 5 studies that were weaker and say had very large confidence intervals, and they found conclusions that were maybe show weak efficacy or actual harm from the vaccine. And so it's one of those things where you just don't want to read every study and take it as the gospel truth. You need to kind of look at the whole spectrum of data that's available and to see, like, okay, what are the strong studies saying? Which are the ones that have the kind of the strongest methodology to them? So that's going to conclude it for this section, and we'll conclude all of the test material for the epidemiology section of the exam. If you have any questions, please let me know, and I'll see you guys soon. Thanks a lot. Bye.